The Genuine Article. Discussion and commentary based on articles from JACC.
Hello, I'm Tony DeMaria, the editor of JACC, here with another edition of The Genuine Article. And today I'm talking to Dr. William Fearon. And Dr. Fearon is Associate Professor of Medicine and Associate Director of the Interventional Cardiology Program at Stanford University. But more importantly, he's one of the major authors on a paper currently in press in JACC that deals with the important question of whether or not we can use angiography to base our therapeutic interventional maneuvers. So, Dr. Fearon, tell us a little bit about the FAME trial, which is the database from which this particular paper was drawn.
Yes, thank you. The FAME trial was a multi-center international study of about 1,000 patients comparing two strategies for deciding in whom to place stents when patients have multivessel coronary disease. And one strategy was a traditional strategy of basing that decision on the angiogram as well as any clinical data available to the operator. And the other strategy was using a coronary pressure wire to first measure fractional flow reserve to determine whether or not a lesion was significant before, hemodynamically significant, before placing a stent. And the primary endpoint of the study was the rate of death, MI, and the need for repeat revascularization at 1 year. And we found that patients who were randomized to the FFR-guided strategy received significantly fewer stents, yet had significantly improved outcomes with about an absolute 5% decrease in the major adverse event rate at 1 year.
Well, there's no question that the FAME trial really did make an impact, showing that functional flow reserve could add importantly. And what's interesting about this paper is you now looked at the ability of visual assessment of a coronary angiogram to determine the functional significance of that lesion. What did you find?
Yeah, so as background, we've really learned about the limitations of coronary angiography, and although it remains the gold standard for diagnosing coronary disease, it can often overestimate or underestimate the physiologic or functional significance of a lesion. And so what we found, we asked the operators to grade the stenosis severity based on visual interpretation of the angiogram, and we divided it into three groups, either 50 to 70% narrow, 70 to 90% narrow, or greater than 90% narrow. And we found that the functional significance of the 50 to 70% lesions, 35% of them were significant, but 65% were not. When you got to the 70 to 90%, 20% of those lesions actually were not significant. It was only the lesions over 90% where the vast majority were significant. So this suggested that between 50 to 90% narrowing were really not very good in judging the physiologic significance, and we need adjunctive techniques like fractional flow reserve.
Well, we've known for a long time that intermediate severity lesions by coronary angiogram are difficult to judge in terms of their functional significance. Mel Marcus showed that very nicely some years ago. And your data clearly confirm that. It is pretty striking that even in the 70 to 90% range of visual assessment, that many of the lesions were not judged to be functionally significant by FFR. Do you think we would have done better if we used electronic calipers or some measurement technique other than just the biretinal algorithm?
Yeah, I don't think so. We've looked at that in other studies and compared QCA, quantitative coronary angiography, to fractional flow reserve, and the comparison isn't any better. There's still a large discrepancy, and I think it's just one of the limitations of the angiogram.
Well, now that you've had this experience, are you doing routine FFR measurements in conjunction with coronary angiography?
Certainly in most cases, if a patient comes in with single vessel disease and has a 80% narrowing and a non-invasive test showing ischemia in that region, I think fractional flow reserve isn't necessary in that setting. But more often than not, we have patients who have maybe one very tight, 90% lesion, and then one or two other lesions in other vessels in the 70% range. And in that setting, I think FFR is really key in helping you decide these other lesions, which ones need treatment.
Well, these are very interesting data, very important data, again showing the limitations of luminology. We've all come to depend on it. We've used it regularly, but in fact there may be better ways to do things in the future. Thanks very much for being with us. For The Genuine Article, I'm Tony DeMaria.
The Genuine Article. Discussion and commentary based on articles from JACC.